Hello, I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. Welcome to this conversation, which is part of our broader series under the auspices of the Value and Access Collaborative that is examining how we move from cardiovascular risk screening to meaningful and impactful treatment and improved cardiovascular outcomes. I am very pleased to be joined today by my colleague and my friend, Ben Bluml, who is the Executive Director and Senior Vice President for Research and Innovation at the American Pharmacists Association Foundation. Ben works with pharmacists, physicians, payers, technology companies, researchers, and public health organizations across the United States to design and implement innovative, patient-centered, team-based care programs and healthcare service delivery systems. Welcome, Ben.
Great to be here, John. Thanks.
Well, thank you, Ben, for joining me. And I want to cut right to the chase, Ben. A 2024 study by Anne-Marie Navarre and colleagues found that most people with atherosclerotic disease, or ASCVD, fail to achieve recommended LDL-C levels. Dr. Navarre and her colleagues reported that failure to initiate or intensify lipid-lowering therapies is the key reason why many patients do not achieve LDL-C goals. And they also reported that among those who do take lipid-lowering therapies, only about half were taking them as prescribed after 12 months. Studies have found that between 1/4 and 1/2 of people with hypertension are adherent to their medications. Now, in the last 10 months, the US has adopted new blood pressure and lipid management guidelines that are based on gold standard science. Implementing these guidelines could prevent millions of heart attacks, strokes, cases of kidney failure, disabilities, premature deaths, and billions of dollars in acute care costs. But as all these studies show, huge percentages of people with these conditions are not getting guideline-directed care. And of those who do, huge percentages do not stick with their treatment plans. Two huge problems that are too big to ignore or allow to persist. I know, Ben, that you've developed system innovations, led studies, and reviewed many others that have identified ways to solve these problems. Now, we can't do everything all at once, so what actions should we take first to raise the number of people who receive guideline-directed treatment for cardiovascular disease and its risk factors, and to improve adherence to those treatments?
Well, I think one of the very significant challenges, and Navarre and colleagues identified this in their 2024 study, but it's a long-standing problem in our healthcare delivery system, and that's one of adherence. And so it's not surprising that patients have a hard time adhering. Typically, they find out about their condition, oftentimes are prescribed lifestyle changes. Often those don't work, and then they're prescribed medication therapies. But after a few weeks or months of taking those medications, they still don't feel any different than the day before they started all of this. And so human behavior is that they stop. And so that striking number in both 2024 and going back decades is that less than 50% of patients are actually adhering to their lipid-lowering therapy, 12 to 24 months on. So I think that focusing on adherence and creating feedback loops with patients and having trusted healthcare providers who they interact with on a regular basis to help them understand how they're progressing with their treatment goals or not, and really support them in meeting them where they're at to try to, understand the importance of lifestyle changes, medication therapy, and other parts of their treatment, so that those silent signs in these silent conditions are no longer silent because they've got meaningful feedback loops that help them to change their behavior.
So, Ben, where do those feedback loops exist, and how can we enable more people to benefit from them to have that as a dimension of their care?
Yeah, well, one of the first programs that I implemented at the APhA Foundation was focused on just this issue, and so what we did was we armed pharmacists with point of care testing technologies in their community pharmacy practices, so that each time the patient saw the pharmacist, they had a touch point. And really interesting results because the feedback loop that they could provide, which supported them in helping them know their numbers and to actually understand their progress or lack thereof, actually kept 93.6% of patients persistent with their lipid lowering therapy over a 24.6-month period. Furthermore, treatment to goal was very substantial when we looked at other similar historical norms and other controlled trials at the time. The team-based care that the pharmacist delivered significantly outperformed single clinician interaction. So it's those multiple points of contact and interaction that the patient has with their pharmacist on the care team that actually can be a significant, factor in changing those behaviors.
So, Ben, you're you just said you gave some eye-popping numbers. You just said a 93.6% adherence rate. Is that right?
Yep. We had 93.6% of patients persisting with their lipid lowering therapy at 24.6 months,
Wow. Wow. Compared to what we
compared
see.
to industry data that indicated at the time that only 32 to 38% of patients would normally have been persisting with their lipid lowering therapy.
At the 12-month period, right?
Yep, that's
Yeah.
right.
Yeah. So twice as long and three times as high. Wow. That's incredible. So why aren't we doing this everywhere? Why isn't everybody receiving these services?
Well, our collective excitement at the American Pharmacists Association has us wondering about that question most days, as a matter of fact, John.
Well,
Um,
what are the barriers, Ben?
some of the significant barriers that we have are that pharmacists, even today, still aren't recognized as providers in the Social Security Act here in the United States. And the barrier that that creates is that pharmacists generally, by both the federal government and health plans, are not currently reimbursed for Part B services. And so, changing that legislation is really important.
So, and I'm glad you just put your finger not only on the barrier, but on the change that needs to occur to lower or remove that barrier. Um, how does not being able to be reimbursed under Part B for delivering services, how does that affect a pharmacist's ability to provide that kind of care?
Well, it actually keeps us stuck in an old paradigm where a lot of people think of their, traditional community pharmacy experiences as being just focused on their medications. But today, every graduate of an accredited pharmacy program in the United States graduates with a doctorate level degree. They have a very significant amount of knowledge, skills, and training that they can apply to not only helping to make sure patients have the right medications, at the right dose, at the right price, but they can also help patients understand their medications and make the best use of them. So imagine for a moment that all of us who are using computer technologies actually had these technologies just dropped on our desk and left there and told, "Hey, good luck. Hope you'll be able to figure out how to make the best use of this." Well, that's what happens to our patients a lot of times with their conditions and with their medications. They may find out that they have hyperlipidemia, as we're discussing here, in a variety of different ways. They may be at a screening event. They may be at a doctor's appointment, and they're told they have high cholesterol, and so they basically are asked very quickly to change what they eat, to change their lifestyle, to do things they don't like, to eat things they don't like, and that doesn't get them to goal. And so now they have to spend lots of money on medications. And as I said earlier, a few months into this, they don't feel any different than the day before they started all of this. And so natural human behavior is that you stop. But what if every time you visited with your pharmacist, you had a touch point in the healthcare delivery system that was supporting you and reinforcing the good behaviors and the good changes that you were making in your lifestyle and adherence to your medication therapy? And what if when you had side effects and challenges with being able to afford your medications, you had a trusted individual there who was basically helping you navigate with those traditional issues that are barriers, but you also had them reinforcing and supporting the good behaviors that help you to get the best use, make the best use of your medications and get the most out of those medications, and actually supporting you with training for that technology that you're putting into your body that's actually helping to get you to a better place and improve your health and increase the number of years that we get to spend on this earth together.
So Ben, are you talking about pharmacists taking the place of physicians and NPs and PAs?
No, I'm not. When you think about the access equation in our healthcare delivery system, first of all, we know that the number of primary care providers, from a physician perspective, is decreasing dramatically. I think that the projections are that by the year 2030, that we're going to be 90,000 plus physicians short from a primary care perspective. And
And we're already short today, right?
they're
It's just
short
that
today.
the
So
shortage is getting worse.
right, it's not getting any better. And so we know there aren't enough healthcare professionals on the planet to get this job done. So doesn't it make sense to include one of the most accessible healthcare professionals on the team as a member of a full-blown patient-centered team-based care model where essentially you've got your pharmacist interacting on a regular basis with patients, supporting them with the medications that have been prescribed for them, possibly by their primary care physician, by their cardiologist, by their nurse practitioner, by the PA, or in some states today, perhaps even prescribed by another pharmacist. So we don't see a situation where we're replacing anybody else in the healthcare delivery system. We see a huge value proposition associated with truly engaging the pharmacist in patient-centered team-based care that makes a difference, because the evidence base for that has grown significantly over the last 3 decades. But now we have to translate what we know works into practices all across America. And that means a different kind of visit with your pharmacist.
So, Ben, how many of people who have primary care providers? Not everyone does, but of those who are fortunate enough to have one and who live in an area where they can get to them readily, how many interactions do they have with a physician or a clinic like that? And how many interactions do they have with a pharmacist? How do those numbers compare?
Well, if you contextually, when you look at this situation, a patient who is typically, of a normal, their health status is at a normal level, they'll probably have an annual visit with a primary care physician. If they have a comorbidity like hypertension or hyperlipidemia or diabetes, they may in fact have another visit or two with their physicians. Probably most of the time, the most that you would ever see happening is somebody who's got a really significant set of comorbidities, and they might have quarterly visits with physicians. Well, guess what? They're visiting their community pharmacist typically over once a month in that practice setting. So imagine that in that practice setting, you actually had the pharmacist on the team, you had them in the communication loop, and you had them supporting the messaging that was coming to the patient about their condition, about their treatment, about their lifestyle changes, and about everything that they need to do to be successful in pursuing better health. You also have to look at the total access picture. And what we know from data from some research that we did a few years ago, and looked at the number of people who pass through the front doors of community pharmacies in this country every 7 days, that the count of the number of people was 301 million individuals. So if you extrapolate that out to 10 days or so, you've got what is the count of the entire population of the United States passing through the front doors of a community pharmacy every 10 days. It's a horrible thing to waste in our healthcare delivery system, such a, highly qualified access point to get to the key issues that our patients need to support them in, both initiating and continuing with their ongoing therapy for their chronic conditions.
Wow. So if I'm hearing you correctly, you're saying that the data show that people have encounters, they are seeing pharmacists somewhere between 4 and 12 times more frequently than their physicians or their primary care providers. Is that right?
That's right. And so just imagine that that pharmacist is connected to, tuned in with, and coordinated with messaging that's consistent with what their physician is providing
Yeah.
them. What could happen with that team? Back to some of those results we were talking about earlier, what we see consistently is that patients achieve better outcomes from a clinical perspective, from an economic perspective, and from a humanistic perspective when they're supported by and wrapped around an entire team of healthcare professionals.
Hmm.
And this is what we're talking about. So we're not talking about there aren't enough of us to get the job done today. Okay. So what we've got to do is work smarter, not harder, as we look to find innovative ways to redesign our healthcare delivery system. And as one of APHA's former CEOs like to frequently say, "Hey, coach, put us in the game."
Right. Well, Ben, you're bringing to mind that the Community Preventive Services Task Force, which oversees the gold standard systematic reviews of evidence, has found that team-based care results in far better patient outcomes. It results in better health. People who receive team-based care are healthier, and that team-based care that includes pharmacists is even better, even more beneficial for people. So, what are some of the barriers that we can clear out of the way? You identified one earlier, that's pharmacists being recognized as providers under, did you say the Social Security Act?
Yep.
Yeah. So, what are some other system or structural barriers that the value and access collaborative stakeholders might join forces to take down, to eliminate so that more people can gain these advantages? By the way, if you go to the communityguide.org to look at those um, Community Preventive Services Task Force reviews, you'll see that not only are they is the team-based care a high impact or clinically high impact intervention, it's also highly cost effective. So there's a benefit not only to the people who are receiving that care, but to every single taxpayer, every single employer, every single family that is paying for healthcare in this country. So where's some low-hanging fruit that through collaborative action we might take to eliminate those barriers or at least reduce them so that we can enable more people to benefit from this care?
Yeah, I think let me talk about it in three different contexts. And so let's think about patients first, and then let's think about providers, and then let's think about payers in our healthcare delivery system. So, first and foremost, from a patient perspective, what if there were ways that you could actually receive incentives from your health plan for actually doing the right thing as it related to initiation of therapy and continuing with therapy that had been prescribed for you that ultimately reduces your risk over the long term and improves your health and your quality of life? If from a provider perspective, what if we change the system so that regardless of which healthcare professional is interacting with the patient, they're fully informed. They have the information that they need at their fingertips because they're sharing information properly. And each of those healthcare professionals are paid fairly for their services and the contributions that they make to helping patients improve both process and outcome measures. And what if, from a payer perspective, payers were able to avail themselves of new and different models in our healthcare delivery system, where if they change the way that they're paying for care and the way that care is being
Hmm.
delivered, that they too can spend less in total over time? Well, those are the kinds of changes that we're seeking, and there's a variety of pathways to that. There are regulatory and policy levers that we can pull. There are, things that providers and payers can initiate on their own. But one of the big things that's front and center right now, we were talking about technology earlier, and interoperability is really a very significant challenge in our healthcare delivery system today. In fact, for decades, many of us have been toiling in this space, and we've seen significant progress in terms of standards and opportunities that have moved us toward a more integrated flow of information within our healthcare delivery system. But today, the Office of the National Coordinator of Health Information Technology has a new framework called the Trusted Exchange Framework and Common Agreement that allows healthcare professionals through a coordinated network of qualified health information network participants to actually have better access to data and to create a single and common point of trusted exchange for that data. And we believe that if we get pharmacists plugged into that in a proper way, So instead of just having dispensing systems in their practice, which are focused on delivering that product in an effective way to the patients who they serve, if they also have interoperable electronic health records in their practices, and they contribute to those EHRs, and that information is shared with other healthcare professionals, both in community practice settings where patients are, 99 point what percent of their lives, but also in acute care settings where we're typically information rich in those practices, and information isn't flowing back and forth when patients are admitted to the hospital or discharged from the hospital, and that care needs to be coordinated. And so if we can have information flow that contributes in a meaningful way to that coordination of care. And if you get each of the healthcare professionals who have regular contact with the patient, then we're going to optimize that flow of information and ultimately treatment that our patients receive, and ultimately their ability to achieve long-term goals.
That makes so much sense. I know most of my healthcare providers are on an Epic system, but I've got one who's on Cerner. And so anytime the one who uses Cerner is trying to access my information from Epic, so that he can see the complete picture. It takes phone calls, it takes people getting into systems to send the information. It's really cumbersome. It's a barrier to top-notch team-based care. So how I can imagine that for a pharmacist who's interacting with patients whose prescribers are on any number of different systems, that's a real tangled web. So, how can we detangle it, Ben? How can we achieve the kind of interoperability that you're talking about? What are the barriers? What actions can we be taking? How can the stakeholders work together to take down those barriers?
Well, again, we believe that it's back to the interoperable electronic health record. And innovative pharmacies right now today are beginning to implement those EHRs in their practices. And in particular, we think that this is essential that it happens in traditional community pharmacy practice
Mm-hmm.
settings. And so imagine for a moment that challenge that you just described of the fact that, well, one of your physicians uses one system, another specialist uses a different system. Those systems aren't talking to each other. But imagine if all of those systems that your physicians are using, and now the systems that pharmacists are beginning to use, actually are widespread. And
Mm-hmm.
imagine that they're all contributing to data in this TEFCA framework, and they're doing it through these qualified health information networks. So that when you go to your primary care physician and they're using Epic in your example, and they put information into the system, that information goes up through the qualified health information network. And when you go to your cardiologist or your other specialists, and they might be using Oracle or NextGen or some other system, and they're trying to figure out what's going on with your care, and they can get data from the Qualified Health Information Network that helps them to understand what your diagnosis, your prescriptions, your treatment actually looks like with your primary care physician, and they can interact with it. And then imagine just for a moment if pharmacists were now on the health information highway and they were contributing to those qualified health information networks. We believe that one of the most essential things that needs to happen is that we have a pharmacist authenticated medication list that's accurate and current and up to date. Because I'm sure that we all have stories that we could tell about challenges associated with our own care, perhaps care that we're providing for a parent or a child, where we go into an appointment, we interact with the healthcare professional and within their practice, and we update them about what those medications actually really are, not what they had in their record. And you come back to the next visit and nothing's changed. And the reason why that hasn't changed is because information isn't flowing. So just imagine that in your trusted interaction with your pharmacist, they're in the best position to actually help to make sure you've got an accurate, up-to-date list of your medications. And imagine that that pharmacist, through that pharmacist authenticated medication list, is sharing that with the qualified health information networks. So your primary care physician, your
Mhm.
cardiologist, your nurse practitioner, your PA, anybody who's interacting with you from a healthcare delivery system perspective knows that on date X at time Y, your pharmacist said, this is your accurate, up-to-date list of medications. We know that medication misadventuring is a huge challenge. Watanabe et al. Published a study back in 2017 that basically used 2016 numbers that concluded that for every dollar we spend on medications in the United States today, we're spending $1.55 for misadventuring associated with the use of those medications. So if you think about those numbers in 2025, this country spent over $1.076 trillion dollars on medication misadventuring. So just imagine we used interoperability and all of your healthcare team members contributing to that unified interoperable electronic health record, just an accurate medication list, the improvements that could occur, and the better health and the better outcomes that we could achieve. We think that it's an incredible opportunity, but we're going to have to update the infrastructure, and we're going to have to engage pharmacists as full-fledged members of the patient care team.
Wow. Um, you brought Everett Dirksen to mind in his quote about a billion here, a billion there. Pretty soon you're talking about real money. You're talking about over $1 trillion attributable to medication misadventuring. Ben, I want to make sure I'm understanding what you mean by that term. It's not one I've been familiar with. Is that where, as a patient, I'm perhaps taking medications that are in conflict with one another, or where one medication that one physician has prescribed for me is working against a different medication that a different provider has prescribed? Or what, if that's not it, what is medication misadventuring?
Well, those are two great places to start. Yeah. And so when we think about that, so think about the healthcare delivery team. Who's the medication use expert? Who on that team is actually trained, to be the person on that healthcare team who can help you make the best use of those medications? Well, of course, it's the pharmacist. Okay. And so whether you're talking about a therapeutic duplication, and so I'll tell a story about what happens with transitions of care and some of the challenges that exist there. You have a patient who has multiple chronic conditions, and let's just say that they're on one antihypertensive medication. And we all know that that typically, to adequately control hypertension, most patients are on a combination medication or two or three different medications to actually control their hypertension. So let's just imagine that you get admitted to the hospital. They recognize that one hypertension med on your profile, and they get you in, they get you tuned up for your acute event that you're having, and then a few days later, you get discharged from that hospital. Right now, in today's system, there's not good coordinated communication that often goes on between that acute care setting and the community practice setting where you spend the vast majority of all of your life. Okay, and so in the hospital they prescribed another medication for your hypertension. And let's say that that medication has two different, active ingredients in it, and it was intended to replace that first medication that you were on. And they did that in the hospital, and they've treated you, and now you're discharged. But that communication doesn't go back to the community setting where you're at, and somebody misses that, whether it's your physician not communicating with the pharmacist, or whether it's the discharge planner communication gap that exists. And let's say that that patient actually continues to take that first medication that they were on when they were admitted, and now they're taking the new medication that they're on when they're discharged. But that medication was supposed to replace the other one, but now you're on both. So what happens? Now you've got too much medication that's lowering your blood pressure. You become hypotensive and you fall and you break a hip, and now you're back in the hospital again. These are the kinds of things that are happening not only every day in our country, but multiple times, dozens or hundreds of times every day. Some patient is experiencing this scenario that I just described, particularly if they're a Medicare beneficiary and they're age 65 and older. So this is just one clear example of a therapeutic duplication. You've got drug disease contraindications, you've got drug-drug interactions, you've got incorrect dosage or duration, you've got drug allergy interactions, you've got unmet needs that are not being addressed, and the pharmacist can resolve those right there at the point of care. And they can also help to plan new therapeutic optimizations and intervene with your medical care team to help to make sure that we're getting the best use of those medications and we're getting the right therapeutic outcomes, and we're not seeing those untoward side effects that I was describing.
Ben, that's really helpful. So it sounds to me, as you're painting that word picture, that where the problem is not it may in some cases be the result of a clinician failing to share information appropriately, but it's that's not the nub of it. We're really looking at system barriers and structural barriers that inhibit or prevent the smooth exchange of information, that interoperability you were talking about. Is that right?
That's right. And imagine that in this country, if the federal government and private entities invested in making sure that every pharmacy had an interoperable electronic health record that
Hmm.
actually
Hmm.
connected to TUFCA and the Qualified Health Information Network Secure Health
And
Information
what's
Highway.
TUFCA?
TEFCA. Yeah,
TEFCA.
Trusted Exchange Framework and Common Agreement from the
Okay.
Office of the National Coordinator. So this is brand new. Came into being in 2022. Really started to gather some momentum in 23, 24, and I think that we're starting to see. I think there are 14 QHINs out there, as they refer to them today. But we've got to get all of the members of the healthcare team, pharmacists included, on the health information highway, and we've got to get information for patients being exchanged properly. It's that seamless flow of information between and among patients and all of the members of their healthcare team that's going to really help us to prevent problems from even occurring in the first place, as per the example that I was just providing. We're just oversights or just lack of communication or
Mm.
just not good communication because one provider has one EHR system and another provider has another EHR system. We aren't going to solve it, by actually thinking that the solution is that, every patient and every healthcare provider will use just one system vendor's system. Okay, we have
Right.
to
Right.
meaningfully exchange information through this trusted
Across
framework.
multiple platforms.
Right, right.
Right.
And your
Right.
pharmacist, as a patient, can be trusted to actually help to make sure that we've got an accurate, up-to-date list of the medications that you're getting, and to help you to make the best use of your medications.
So, Ben, it sounds like this has been an infrastructure problem or a lack of infrastructure, and that the Office of the National Coordinator with TEFCA is paving that information highway. So is that
Now,
job being
Now we
is
have to
that being
start. Now
taken
we
care
have to
of?
start driving on it, and that means that we're going to have the right tools and resources to be able to make our way onto the on ramp to get onto that highway and to move back and forth on that highway and to exit and enter where we need to, and to basically have consistent signage and rules of the road and engagement with
Mhm.
all of the members of the healthcare team, and that includes patients and every healthcare professional they come into contact with on their care team.
So, Ben, are there policy and or systems changes that will help everybody get on that road?
Yeah, the policies are there. Now what we have to do, but it's a choice as to whether healthcare professionals and health systems and health information exchanges in our country actually choose to use that health information highway, if you will.
And who needs to make those choices? Where will those choices happen?
Well, I think that when we think back to I talked about patients and healthcare professionals and payers as three primary focal points. So one of the taglines that we've used going all the way back to 1998 at the American Pharmacists Association Foundation is align the incentives, improve the outcomes, control the costs. And in order to do that, you have to make sure that the incentive alignments are properly in place for each of those three audiences. So, first and foremost, for our patients. So, what if they got incentives to do the right thing, to change their and modify their behaviors and their medication taking activities? And what if all of the healthcare providers who were participating were actually paid fairly for their services so that they could be, a fully activated participant on the healthcare team? And what if payers found that, hey, if we make sure that we're incentivizing everybody correctly, we too can spend less in total if we're open to making changes and not just pursuing the traditional pathways. Those are the opportunities that are right now available to us if we all choose to invest in thinking differently about the healthcare system, about the healthcare team, about putting our patients first, about meeting our patients where they are, about empowering them to have information to understand their progress or sometimes lack thereof, so that we can have an ongoing monitoring and management program in place for each one of those patients that helps them to understand. And in our team-based care data, we know that you can get 90+% of patients sticking with it as compared to the 30 to 50% that we're seeing right now today
Okay.
throughout our healthcare delivery system.
Okay. So, Ben, we're down to our last 60 seconds here. So,
Okay.
this will require a quick answer. Are there any levers that patients, providers, public health, payers could might join together to push or pull to accelerate these changes and enable everybody to be able to drive the information exchange highway?
Yeah, I think that right now we've got legislation that's passed the Ways and Means Committee that will actually, formerly called ECAPS, now focusing on improving access to your community pharmacist. And we know that that legislation, if it moves through the House and through the Senate and gets signed by the president, will make a difference because it will actually clear the way to make sure that your pharmacist can be on the team. And then once we get everybody moving secure health information around on our health information highway, I think that we're all going to be in a better place to understand our health and to achieve the best outcomes from medications and other therapies that are prescribed for us.
Sure. So, Ben, one thing we need to do is pull the bill that was formerly called ECAPS across the finish line to get it passed. What is it now called?
Yeah, it's now called the Main Street Pharmacy Access Act. And
Okay.
that'll authorize Medicare Part B reimbursement for pharmacists to deliver services like test and treat and other common illnesses.
Okay. And I think one of the key takeaways from this conversation, this really robust conversation that I've been privileged to be part of with you, is that the evidence, it could not be stronger that people benefit from team-based care, that team-based care helps people attain better clinical outcomes, and it's cost effective. So everybody who pays, whether they're taxpayers or employers or families who are paying for healthcare, everyone benefits when more people have access to team-based care. Team-based care is most effective when pharmacists can be part of the team. And for that to happen, we need pharmacists to be recognized as providers. So that's a policy change. And second, we need to ensure that there's a paved information exchange highway so that all the members of the team can be looking at the complete picture and exchange information. And we have not only work underway on that being led by the Office of the National Coordinator, but we also have policy changes that can help to accelerate that and systems changes as well. We need all different types of providers to embrace this. Is that a fair summation?
That is a great summation, John. And we look forward to being a part of the solution that helps people to improve their health and improve the quality of their lives.
Well, thank you very much, Ben Bluml. Pharmacists play an increasingly important role in medication management, patient counseling, adherence, and team-based cardiovascular care. And I think by all of us working together, we can help more people have access to the team-based care that we know will help them reach their goals, maintain that success, and help to prevent heart attacks, strokes, heart failure, kidney failure, and premature deaths and disability in every part of our country.